Today, I want to talk to you about something that I think is critically important for anyone involved in healthcare, whether you are a clinician, a researcher, a developer, or even a patient. We need to talk about why high accuracy claims in medical AI can be deeply misleading, and why a 99% accurate system might actually be a complete failure. Now, I know that sounds counterintuitive. We have been conditioned to think that higher accuracy is always better. If someone tells you their AI diagnostic system achieves 99% accuracy, your natural reaction is to be impressed. That sounds remarkable. That sounds like the system is getting things right almost all of the time. But here is the problem. In medical diagnostics, that number can hide a devastating truth. Imagine this scenario with me. A developer proudly announces that their new AI screening system achieves 99% accuracy. Sounds great, right? Now imagine that same system fails to detect a single case of disease among all the patients it screens. Every cancer missed, every stroke overlooked, every treatable condition allowed to progress unchecked. How can both of these things be true simultaneously? How can a system be 99% accurate and yet miss every single case of disease? This is what we call the accuracy paradox, and understanding it is absolutely essential for anyone working with or evaluating medical AI systems. So let me explain how this works. The key lies in understanding class imbalance, which is a fundamental characteristic of medical data. When we collect health information from large populations, most people are healthy. Only a small fraction have any particular condition. Consider atrial fibrillation, which affects only 3 to 5% of adults. Or think about breast cancer screening, where fewer than 1% of mammograms reveal malignancy. Or consider malignant arrhythmias, where the imbalance ratio can exceed 10,000 to 1. In medicine, the healthy are many, and the sick are few. This is simply the nature of disease epidemiology. Now, here is where the paradox comes in. In a dataset where 99% of patients are healthy and only 1% have disease, a classifier can achieve 99% accuracy by doing absolutely nothing useful. It simply predicts healthy for everyone. Every healthy patient is classified correctly. Every sick patient is incorrectly told they are fine. The math is brutally simple, and it exposes a fundamental flaw in how we evaluate these systems. Let me walk you through a concrete example to make this clear. Consider a population of 1,000 patients, where 990 are healthy and 10 have disease. A trivial classifier that always predicts healthy will correctly classify all 990 healthy patients. That is 990 true negatives. It will also incorrectly classify all 10 diseased patients as healthy. Those are 10 false negatives. The accuracy is 990 correct predictions out of 1,000 total, which equals 99% accuracy. But the sensitivity, which is the proportion of actual disease cases correctly identified, is 0%. The system has detected none of the disease cases, 0 out of 10. Now compare that to a useful classifier that actually learns disease patterns. This classifier might correctly identify 950 of the 990 healthy patients and correctly identify 8 of the 10 disease cases. It has some false positives. 40 healthy patients incorrectly flagged as potentially diseased. And it has some false negatives. 2 disease cases missed. The accuracy here is 950 plus 8 divided by 1,000, which equals 95.8%. That is lower than the trivial classifier, but the sensitivity is 80%. 8 out of 10 disease cases detected. So here is the critical question. Which system would you rather have screening your patients? The one with 99% accuracy that misses every single disease case? Or the one with 95.8% accuracy that catches 8 out of 10? In medical diagnostics, that 4% drop in accuracy is vastly preferable to missing every single case of disease. The trivial classifier is useless. The useful classifier actually serves its intended purpose. This brings us to a crucial point about the asymmetry of medical errors. Not all diagnostic errors are created equal. In healthcare, the consequences of different types of mistakes vary dramatically. A false negative, telling a sick patient they are healthy, can have devastating consequences. Disease progression beyond treatable stages, delayed interventions when timing is critical, patient harm from false reassurance, preventable, disability, or death. A false positive, telling a healthy patient they might be sick, causes anxiety and additional testing, sometimes unnecessary procedures, but ultimately the error is discovered and corrected. The consequences are asymmetric by design. In medicine, the cost of missing a cancer typically far exceeds the cost of an unnecessary biopsy. A screening test that generates some false alarms but catches every true case serves its fundamental purpose. A test that never alarms but misses every case has failed completely, regardless of its accuracy score. Let me walk you through what happens when AI systems fail to detect disease early. The consequences cascade through a patient's healthcare journey in predictable and tragic ways. In the early stage, the AI's low sensitivity causes the first failure. The patient receives reassurance that nothing is wrong. They leave the clinic believing they are healthy. As time passes, the undetected condition advances beyond the stages where treatment would have been most effective. The disease that could have been caught early is now progressing silently. By the time symptoms become impossible to ignore, critical intervention windows have closed. Timing-sensitive treatments can no longer be offered. What might have been a straightforward early intervention now requires aggressive treatment with uncertain outcomes. Ultimately, the patient suffers negative health outcomes, potentially including permanent disability or death, all stemming from the false reassurance provided by an AI system that appeared highly accurate but could not actually detect disease. This progression from misdiagnosis to patient harm illustrates why sensitivity, not raw accuracy, must be the priority metric when evaluating medical AI systems. So, if accuracy fails us, what should we use instead? Let me walk you through several alternative metrics that actually capture what matters clinically. First, sensitivity, also called recall. This tells us what proportion of actual disease cases the system correctly identifies. It directly answers the question, if I have the disease, will the AI find it? Second, specificity. This measures the proportion of healthy patients correctly identified as healthy. It answers the complementary question of how many false alarms the system generates. Third, the F1 score. This combines precision and recall using a harmonic mean that penalizes extreme imbalances. A classifier cannot score well on F1 by excelling at only one dimension. It ensures balance. Fourth, the Matthews correlation coefficient. This incorporates all 4 cells of the confusion matrix and treats both classes symmetrically. A score of 0 represents random guessing. A score of 1 represents perfect classification. Fifth, balanced accuracy. This simply averages sensitivity and specificity, giving equal weight to both classes regardless of how imbalanced the dataset is. The key insight from all of this is straightforward. Never trust accuracy alone in imbalanced medical data. Always examine sensitivity. Ask whether the system can actually detect disease when it is present, because that is the fundamental purpose of a diagnostic tool. I want to leave you with some specific calls to action, because understanding this problem is only valuable if it changes our behavior. For clinicians, question any AI system claiming high accuracy without also demonstrating robust sensitivity data and evidence of healthy learning dynamics. Do not be impressed by accuracy numbers alone. Ask to see confusion matrices. Ask about sensitivity. Ask how the system performs on the minority class, the disease cases it is supposed to detect. For developers, design your evaluation protocols to genuinely reflect clinical priorities and patient safety. Collaborate closely with medical professionals who understand the real-world consequences of diagnostic errors. Do not optimize for accuracy when sensitivity is what matters clinically. For patients, become advocates for clear and transparent AI performance reporting in your healthcare settings. You have the right to understand how these systems are being evaluated before they are used in your care. Ask questions. Demand transparency. For everyone, demand confusion matrices and learning curves, not just headline accuracy figures. The details matter. They determine whether AI helps or harms. Let me summarize the bottom line. A 99% accurate AI system that misses every single case of disease is not a success. It is a failure, dressed in impressive statistics. As we continue integrating artificial intelligence into healthcare, we must resist the seduction of simple metrics. The question is not how often is this system correct. The question is, does this system catch the diseases it was designed to find? In medicine, the stakes are not measured in percentage points. They're measured in human lives. For those of you who want to explore these concepts in greater depth, I have written about evaluation frameworks for medical AI in my book, Diagnosing AI: Evaluation of AI in Clinical Practice. That book provides detailed guidance for clinicians, researchers, and healthcare administrators who need to rigorously evaluate machine learning systems before clinical implementation. Thank you for listening today. I hope this episode has given you a new perspective on how to evaluate AI claims in healthcare. Remember, high accuracy can mean complete failure when it comes to medical diagnostics. Always look deeper. Always ask about sensitivity. And always remember that in medicine, the cost of missing disease almost always exceeds the cost of a false alarm. I am Dr. Milan Toma, and I look forward to continuing this conversation with you. Take care.